All right, everyone, it's that time. Let's go ahead and get started. So welcome, everyone. I see we already have a good group of people gathered here on Zoom. And as you can see, today we're going to be doing a free webinar together. And the topic we're going to cover is basic care and comfort, testing your nursing knowledge. So guess what we're going to be doing a lot of today? A lot of questions, basic care and comfort questions. So get ready to answer some questions today. So first of all, for those of you who don't know who I am, my name is Elizabeth Diger. I'm actually a women's health nurse practitioner. I did that for about a decade. I also worked several years as a critical care nurse in the ICU and ER settings. And of course, now I'm a teacher here at Archer Review. I've been doing this for about 2.5 years, and I love it. Now, let's talk about basic care and comfort a little bit. Remember, the NCLEX exam really assesses your ability to provide safe and effective care in a variety of nursing situations. And basic care and comfort is one of the categories that the exam is going to evaluate. It includes aspects of nursing care that are really fundamental to promoting well-being and comfort of our clients. Now, it covers some key topics, and we're going to be doing questions from all of these different topics today. It covers hygiene and personal care. Of course, we as nurses help with bathing and grooming. We provide pre and post-op hygiene. This is also going to cover mobility and immobility. So, yep, we help people with ambulation, but on the other side, if someone's immobile, we have to help prevent complications of that. This is also going to cover nutrition and oral hygiene. We're going to do some questions from that as well. We're going to do questions on elimination, comfort measures, rest and sleep. Assistive devices shows up in basic care and comfort. That can be tricky, especially the crutches. And then it's going to cover alternative and complementary therapies. So don't neglect basic care and comfort. A lot of people see basic and they think, oh, this is going to be easy, but it can really be quite complicated, as you can see from some of the questions that we're going to do today. Now, before we get started with the basic care and comfort questions, I do have Slido for you guys. We're going to be doing Slido throughout today's presentation, and you can join at slido.com. You can do that in two ways. You can actually go to slido.com and use the code #BasicCareAndComfort, or you can scan this QR code in the lower left-hand corner. But you guys are already answering. Tell me in the chat, tell me in Slido, where are you guys coming from? Looks like all over the place. And by the way, for those of you in the Zoom with me, feel free to use the chat. You can communicate with me in the chat. But remember, if you have any questions, we have the wonderful Jennifer Bonner on today. She's going to be answering those questions in the Q&A section, in the question and answer section. And also remember, don't use the raise hand option. I'm not going to have time to call on you, but use that chat to interact with me. But we literally have people from all over the world joining us. I can see in the chat, we have people from all over the United States, India, Africa, the Philippines. This is great. Let's see. Singapore, London. This is what I love about these webinars. It really brings people together from every corner of the world. It's a really cool experience. Okay. Well, what do you guys say? Are you ready for some questions? We're going to be doing a lot today, and we're going to do them pretty quickly. So get ready. We're going to do a lot of questions. Okay, we got some yeses. All right. Now, the first type of questions we're going to do pertain to vital sign changes. So not only do you have to know the normal vital signs, you have to know, okay, if something is changing in the vital signs, what does that mean? And what do I actually do about it? Okay. So we have our first question here, and we're going to take just about 30-40 seconds per question. So our first question says, what is the correct site for measuring the client's pulse rate? So where do we measure the pulse for adults? For adults, I should say. Getting a variety of answers. Most people are agreeing. Ooh, I like this, carotid or radial. It does depend on the situation. And I agree with what most of you guys are saying in the chat. Depends on the situation. I agree. Let's take 10 more seconds. All right, let's see what it is. The radial artery, that radial pulse in the wrist. That's ideal. That's what the NCLEX is usually going to want you to say. Now, that's the opportune place to check the pulse. Of course, if you're just, if you're just checking vital signs, we're going to use that radial pulse. But just like you guys were saying, if we're in like a code situation and we need to see if someone's having a pulse, in adults, we're also going to use the carotid. So if it's a code, carotid. You guys got that well. Okay, next question. We're going to do a lot together. Tell me, this is a hard one. What does the top number, the systolic number, represent when you're doing a blood pressure reading? What's actually happening physiologically? So what does it represent physiologically? What's happening in the cardiovascular system? Not a number, although you're right, 120 is the normal for the systolic blood pressure. You guys are getting it. You know your anatomy and physiology. Very good. Julian, nice job. You guys got it. Again, absolutely. Basically, the systolic is the pressure in the arteries when the heart beats or contracts. So when the heart is actually contracting, that's when the blood pressure or that systolic number is going to be at the highest. On the other hand, the diastolic number, the lower number, is when the heart is relaxing and filling with blood again. So it's good to know what those actually mean. This is kind of an interesting one. It's a charting question. This question says, how would you document a respiratory rate of 18 breaths per minute? What's the correct way to document? So I wouldn't just put normal. Normal doesn't tell you enough. You got to really tell what is the clinical information. So this one's tricky. I'm seeing some good answers here. Okay, good. So if I'm doing a respiratory rate and it's 18, I'm not just going to say, okay, respiratory rate was normal, right? That doesn't really pass on any critical information. We don't know how many breaths per minute the client has if we just put normal. That would be an assumption to decide that. So you actually have to put the rate in. You have to put respiratory rate or RR colon 18 breaths per minute. You really need to give all of that information so the next shift person, whoever's taking over for your client, that they can monitor those trends. Because it's normal to have a respiratory rate of 14. It's normal to have a respiratory rate of 18. But if those numbers are changing, we want to know those trends. So you actually do want to put the numbers in. So, okay. Yeah. And you would also want to put what you're auscultating. Is it clear to auscultation? That sort of thing. Good thinking. Okay. Name 2 factors that can affect a client's blood pressure. I bet you can name more than 2 even. What are some things that manage or affect a patient's blood pressure? Good. I'm seeing some great answers in both the chat and Slido. I like that you guys are acknowledging that it's not just modifiable things, there's also some non modifiable risk factors. You got to think about both of those. Good thinking. Yeah, exactly. Good. Let's take 10 more seconds. You guys are coming up with some really, really good answers. Family history, that's non-modifiable, versus diet and stress level and weight, potentially a little bit more modifiable. Exactly. So you guys hit a lot of these. Being stressed, the older you get, the risk for high blood pressure goes up. Obesity, medications, activity level. And just like you guys said, genetics plays a really big role as well. That family history is significant. You guys hit a lot of them. You had more than even we have on this list here. Good job. They could quiz you on any of those on the NCLEX. Okay, now let's switch over and let's do some questions on hygiene and skin integrity. So it's a really important part of basic care and comfort. And again, it's really easy to neglect this when you're studying, but they definitely ask questions on this. So let's do a couple. All right, this question says, what is the purpose of peri-care for a bedridden client? This is an interesting one. What do you guys think? Use chat or Slido. And remember, if you have any questions, Jennifer's waiting for you in the Q&A. She can help you there. Good. Yeah, infection is one of the key points. Skin integrity. Yep, we've got to keep that skin healthy. Yeah, especially those UTIs in our female clients, especially. Good. Yeah, to avoid fungi or bacterial infections. And I like that, Rose, to provide dignity. Yeah, we want to treat our clients with respect, and maintaining their hygiene is part of that. I very much agree with that. So absolutely, it's to maintain cleanliness, it's to prevent infection of the genital and perianal regions. And I agree, Fabian, that is true. It's especially important if your client has a Foley catheter. Remember, if your client has a Foley, that's a pathway that bacteria can take to travel up into that renal system, into that urinary tract, and that can cause an infection that gets out of hand really fast. So, especially if your client has a Foley, really every single day at a minimum, we should be doing that peri-care. Good. Okay, let's try this one. What type of bathing technique is recommended for a client with a localized skin infection? Yeah, you put that perfectly. I exactly. Warm water, get some, yeah, just partial. Exactly. We could get some washcloths with wet with some soapy water and just kind of focus on that localized area. Exactly. I like that. The washcloth in the bag, heat it up, get it all soapy and use that. Exactly. Yep. Make sure it's warm. Make sure it's gentle for our client's skin. Totally agree, guys. We're just going to do that partial or localized bath. I think one of you answered it exactly that way, which was perfect. Okay, this is an important one that shows up a lot on the NCLEX. Oops. Uh-oh. My Slido acted funny there. Let me just reset this. So sorry about that, guys. Slido is acting goofy. Okay, so it's up and running again. I'm not sure what happened there. So you guys are answering. How would you prevent pressure ulcers in a bedridden client? Good. Repositioning. And tell me in your answer, how often at a minimum do we reposition? That's what they ask a lot on the NCLEX. You need to know how often to reposition. Good. You guys are getting the main point. I agree. You guys got it. You guys totally got it. We've got to regularly turn and reposition. And the answer for how often is exactly a minimum of every 2 hours, potentially more. If you have someone who's especially high risk for pressure ulcers, I might check them even more. Additionally, we should use good surfaces to lay our client on. We need to maintain good nutrition and hydration. The other big thing is make sure your client's skin isn't wet. If it's moist, if they're wet a lot from sweat or incontinence, yeah, you need that dry skin. Otherwise, that breaks down the skin much faster. And that's one of the big hidden risks for pressure ulcers. So just don't forget that as well. Okay. We've got another one. We're going to keep coming at you. Name two complications that can arise from poor oral hygiene in hospitalized clients. So I bet you could come up with one really easily, but think deeply, think critically about what complications we could see. Oh, very good. I'm impressed by how many of these you guys are getting. Very good. Mm-hmm. Good catch with that. Okay, let's take a peek. You guys even came up with a couple that I don't have on my answer key here. Really, the big ones are going to be dental cavities, of course, but a lot of you guys also said gingivitis, which is very true. Gingivitis can affect your health in other areas. It can affect your cardiovascular health, for example. So that was a good one. And then, of course, if bacteria is building up in the mouth, it could lead to an aspiration pneumonia as well. Very good. And I liked thrush as well. Thrush, fungal infections of the mouth, that potentially could be a risk, especially if your client is using steroid based inhalers, remember. Okay, let's keep it going. Ooh, this is a good one. What is the correct procedure for cleaning a wound? So think about this. You got an open wound bed in the skin. How do we clean that in the best way possible? Oh, I thought this one might trick you, but apparently not. Good job. Ooh, kind of getting some varying responses, but most of you guys are getting this. Yes. I like that. Yes. Let's take 10 more seconds. I'm still seeing a lot of good answers coming in. Okay. Yeah, I'm so impressed by how many of you guys got this. We need to clean from the inner portion, the center moving outwards. That's really the critical part of the answer they're looking for. And of course, we can use saline or wound cleanser depending on what the order is prescribed. But it's critical. If you wash from the outside in, you're potentially draining bacteria, Staph aureus, from the skin into the wound. That could cause an infection like MRSA, and that can get out of hand really, really quickly. So you wash from the inside out. And something someone else said that I really liked is you want to use one, if you're using any type of swab or gauze, you don't just keep using the same one and rubbing it around. You use one, swipe, throw it away. One, swipe, throw it away. You don't want to spread the bacteria. So that was very smart. Okay, let's take a quick pause. We always get a lot of questions about our different products during these webinars. So I'm going to pause a couple times just to tell you what those are, not to pressure you into it, but in case you're interested. And really, if you're a repeat test taker, our number one recommendation is going to be Intense Prep. And that's the program I like best. It's really, really cool. So let me just briefly tell you about it. Basically, it has 5 key portions that make it so effective. It has a really structured schedule. It's a 6-week schedule. And let me tell you guys, if you can really commit to the schedule, it's a lot, it's busy. But after that 6 weeks, you are going to be ready to take that test and pass it. It is a very comprehensive, effective schedule. Additionally, you get to meet with a tutor twice a week for 2 hours. You're going to have a class size of up to 25 students, and you get time there to ask questions, to go over tricky content, and to do questions as a group to learn those question strategies. Additionally, there are 3-hour live reviews twice per week, every Tuesday and Thursday. I'm one of the lecturers for that, so obviously I'm a little biased, but I think they're great. They cover the big topics that are going to show up on the NCLEX, and what's nice is you can attend them live and you can ask questions, which is so nice. You also get our wonderful Q bank, over 2,800 questions. Your tutor is actually going to analyze your work in the Q bank, and they're going to provide you weekly feedback. What are your weaknesses? How do you improve those? And then you get our electronic ebook. It's actually about 1,400 pages long. It is packed with content that is there to help you pass the NCLEX. So if you're interested, again, no pressure if it doesn't seem good for you, but if you are interested, you can scan the QR code here. And again, it just includes so many different things. We do have a new group. I actually think it's starting the 28th, now that I'm thinking about it, next Monday. It's going to be taught by Lauren Korth, one of our experts here at Archer, and it's $400, $399. So just something to think about. Something else to think about real quick, and then we'll get back to those questions, is if you're wanting that private tutoring, if you're needing that individualized attention, another really effective way to get that is private tutoring. It's going to be $75 for the hour, and you get completely individualized attention for that hour. And your tutor can do whatever you need. They can create a study plan. They can go over content that you're struggling in. They can analyze your work in the Q bank and figure out what you're weak in. And they can also tell you, are you ready to test, or should you push that back and wait? That's one of the best things they can do. So I do some private tutoring. And as you can see, we have a ton of wonderful tutors. They're all excellent. So, okay. Let's get back to it. Next, we're going to be doing some questions on mobility and immobility. So, of course, you got to know how to help people move and ambulate, but really, you're going to get the most questions on the NCLEX about immobility. How do you help someone if they're immobile? How do you prevent complications? So our first question says, why is turning and repositioning important for immobilized clients? I bet you could use some knowledge from a prior question to help you with this one. Yeah, that's one of the big things. Ah, good. I like that addition of circulation. but you guys are getting the key point. Yeah. Ooh, I like that too. Prevention of pneumonia. Very good. I like that. We'll talk about that in just a moment. 10 more seconds. Ooh, prevent contractures. That's a complication of immobility. You guys are good. All right, let's look at the answers. So we have two of the big things here. Yeah, it's going to prevent those pressure sores. It's going to promote circulation, but I'm impressed by how many others you got. Remember, if someone's immobile, fluid collects in their lungs, atelectasis. It could lead to pneumonia. We want to prevent that. Clients who are immobile, their blood is just sitting in their extremities. They could get DVTs. They could get blood clots. Moving them helps prevent that. Doing passive range of motion, that prevents those contractures that you guys were talking about. Very impressive. You guys have clearly been studying this. Okay, and we just talked about these. I'm going to skip that one. We just talked about those actually. Okay, let's do this one. This is a new one. It says, describe the proper technique for using a mechanical lift to transfer a client from the bed to the wheelchair. And think about every step, because if you omit a step on the NCLEX, they're probably going to ding you for it. So be complete with your answer here. Very smart, Rena. That's something that I bet a lot of people forget to do. Very smart. Use proper body mechanics. I like that. I agree. Two people, probably safer than one. Lock the wheels. I bet so many people forget to do that, right? It's such a big safety issue. Have the client close to the wheelchair. Lock that wheelchair. Lock the bed wheels. Yes, this is what I'm looking for. Put the sling under the client. Exactly. Okay, 10 more seconds. Yeah, you guys did really well. Again, you guys come up with ideas that aren't even in the answer key, which is really, really good to see. So, absolutely, we need to lock the wheels. I think that should be the first step. And then we need to place the sling under the patient. We need to attach the sling to the lift. We're going to use the machine to elevate the client. And then we're going to move them to the wheelchair. And just like you guys said, the wheelchair shouldn't be on the other side of the room. It should be right next to where we're using the lift. That's going to prevent complications and injuries. Very good. Okay, we also kind of touched on this a little bit. Remind me, guys, how can you promote joint mobility in a client who has been bedridden for an extended period of time? Remember one of those complications we talked about? You guys are. Good job. Yeah, I like the regular turning and repositioning again. That's very helpful. So exercise sounds good, but remember, this person is bedridden. They might not be able to follow commands. Okay, 10 more seconds. I know we're going fast, but I want to get to as many questions as possible. Good. Exactly. Yeah. To really promote joint mobility, we should be doing that passive range of motion. How, tell me in the chat, guys, how often should we do that passive range of motion? And yep, we're going to turn and reposition. We might use physical therapy, but should we just do? I would actually say more than every shift. I would say if you're going to be turning the client every 2 hours, I would probably add in that passive range of motion every 2 hours. Those contractures, that tightening of the muscles and the scarring of the muscles can happen faster than you'd think. So I would say about every time you turn and reposition the client, that could be appropriate to do. This is a little tricky. This one says, explain the importance of using a trochanter roll for a client with a hip fracture. Trochanter roll. I bet at least a couple people that's new to you. Good. Very good rationale there. Mm-hmm. Yes. This is a very good explanation. Prevents external rotation of the affected leg, remains neutral positioning of the hip joint. Very well said. Yeah, we don't want that hip to move. We want to immobilize it. Exactly. 10 more seconds. Maintain alignment. That is a very succinct way to say it. Exactly. Yep. We need to maintain that proper alignment. We want the hip to be just straight forward. We don't want it externally or internally rotated because that could actually cause more injury. It could cause harm to your client. So we do not want that rotation. We want that neutral position, and we can maintain that with the trochanter roll. Good, exactly. Okay, now let's switch gears and let's talk about pain management. You bet this is part of basic care and comfort, actually. All right, this first question sounds basic, but they could ask you on the NCLEX. This question says, what is the difference between acute and chronic pain? How do you define those? Ooh, I see that you guys are even giving me some time frames. Very, very good. Yes, you're giving me that time frame. 3 months is typically the standard. Exactly. So I would actually say 3 months instead of 6. Yep, acute, short term, chronic, long term, but make sure you know the time frames as well. Yeah, you guys know the definitions. Acute pain is short term. And by definition, short term is less than 3 months. That's the definition for the NCLEX. And of course, if acute is less than 3 months, chronic is long term. It's pain persisting past that 3 month mark. So that's where you need to know that time frame. Good job. Okay, so of course, as nurses, we should always be using the least invasive method first. So tell me, what are 3 non-pharmacological interventions for pain? We shouldn't be jumping for the running for the analgesics right away. We really shouldn't. Ooh, deep breathing is my favorite. I like the box breathing method. I don't know if any of you have heard of that. Guided imagery is quite good. Distraction, it works well. Ice and heat. Good thinking. Listening to music, meditation is very nice. Hydrotherapy, I like that one too. Very, very good job. Music can be healing. Totally agree. Yeah, you guys, again, you have way more than our on our answer key. Exactly. Relaxation techniques, distraction, massage. You got to ask first for that one, but offering massage can be helpful. Heat and cold therapy, guided imagery. Like I said, I really like breathing exercises. Depending on the cause of the pain, I agree, Rena, a dark calm room can be very, very helpful as well. I like your thinking. Okay, let's try this one. How would you assess pain in a nonverbal client, such as an infant or maybe someone with severe dementia? They can't tell you if they're in pain. How do you detect that? Facial expressions. Yeah, you can't really control those very well. So, a pain scale, the numeric pain scale, requires the client to rate it. They'd have to be able to talk. But I agree. Facial grimacing, yeah, that's an indicator of pain. Agitation, changes in mental or level of consciousness status. Vital signs. Tell me in the chat, guys, what's going to happen to the vitals if someone's in pain? Are they going to go up or down? They're going to go up. Yes. And then vocal cues, exactly. Crying, moaning, grunting. These are some big cues as well. So exactly, changes in behavior, changes in facial expression, body language, physiological changes. These are all indicators of pain. And you really got to keep your eyes open for them if your client's nonverbal. You can miss some of these cues pretty easily. This one I think is kind of hard. It says, what is the analgesic ladder and how is it used for pain management? I bet this is maybe new to a couple of you. It's not used, that term isn't used very often. True. Yep, less is more. Yeah, never heard of it. I bet a bunch of people are going to say that. I like that emoji. What are you talking about there? Good. Yes, it's all about going from least to most invasive. Remember, that's how we provide nursing care. So think about if we're going to use analgesics, what's the least invasive analgesic we're going to use first? Yes, exactly. We're going to use the non-opioid, and then only if those don't work, we're going to use the opioids. Exactly. Yeah. So, really, the analgesic ladder, for those of you who are like, what is she talking about? It's basically a stepwise approach to pain management. We're going to start with the least invasive, the non opioids like NSAIDs and acetaminophen. And only if those don't work, yeah, we're going to check back maybe in like 30 minutes if they're still in pain. Then we could use the opioid, but we don't jump right to the most invasive method. We don't jump right to the opioid. We try non-invasive things first, or less invasive, I should say. Okay. Oh, I like this one a lot. This could come up very easily. It says, discuss the importance of addressing cultural factors when assessing and managing pain. Ooh, that's true. Sybil, I like that statement. Yeah, you don't want to have bias. Exactly, true. I was going to use that example. Yeah, some cultures don't show pain. That was good. I was going to use that. I'll bring it up again in just a minute. Do not assume. Yeah, some cultures view pain differently than other cultures. Some remain stoic, some are pretty open about if they're in pain. Okay, this is true. Pain is what the client says it is. Yes, I totally agree. Yeah, so basically, cultural beliefs and practices do for sure influence how pain is experienced and how pain is expressed. So that can really impact pain management strategies. And just like you guys said, I had an example, and one of you guys gave it very cleverly. Is, especially Asian cultures, not all, but some, these individuals are typically a little bit more likely to downplay their pain. They're less likely to express their pain, and they're more likely to be kind of stoic. So you should be aware of that, because that might impact how you treat that client a little bit. So great job. I loved that example. Okay, pause real quick. This is a short pause. I just want to quick tell you about small group tutoring, because this is just another method to help get you where you need to be to take your NCLEX and pass it. If you're someone you're like, private tutoring, it's a little much. I just want to review a very specific topic. Then small group tutoring is a very cost effective and efficient way to learn a variety of things. And basically, it's going to be $25 for the hour. As you can see, there's a ton of different small group tutors, and we all kind of have different specialties. And you can pick what you're weak on, and they're going to cover that in that hour. For example, Kate, she's our cardiac queen. If you have trouble with EKGs, Kate's your girl. She is so good. Versus if you're weak at pharmacology, that was me in nursing school. I was not a pharm fan. Lauren Korth, she's really a pharmacology expert. We also have the wonderful Jennifer Bonner. She's really a women's health expert. She's actually a midwife. So you definitely want to see her for women's health needs. And then I do the different test plan areas. And for example, I do one on basic care and comfort. So if you're interested, just scan that QR code and you can check out all the different classes we have. They're really good. Okay, now it's time to do some questions on nutrition and elimination. Okay, this question says, what is dysphagia and how would you assist a client with it during mealtime? So you have to know this medical term first. Just a reminder, guys, if you have questions, make sure you put those in the Q&A. Otherwise, Jennifer might not see those. So just put any questions you have for Jennifer in the Q&A. Yes, you guys know difficulty swallowing. Yes, that's what it means. You got to know that term. So let's take it a step further. How do you help someone who has difficulty swallowing? They're a huge aspiration risk. Small bites, small sips. Check on them. Very smart statement. Position them correctly. Thicken liquids. I like that one. Ooh, swallow, chin down. That's my favorite. I'll talk about that in just a minute. You guys did great. Yeah, exactly. Dysphagia is difficulty swallowing. And just like you guys said, these clients are going to have aspiration risk. You really got to watch them carefully, but you can help these clients. You can modify the textures. Like you said, you can thicken up the liquids so they can swallow them more easily. You need to position them in a high Fowler's position, ideally. That's going to help them not to aspirate as easily. And then, of course, you need to monitor them for aspiration. But one that one of you said, really, really smart, was chin down. This is something that I always did with clients with dysphagia. What I would tell them is every time you swallow, chin to chest, chin to chest. And as you swallow, you're going to gulp with chin to chest, and that actually helps to close off that airway. It makes it less likely that the client will aspirate. So very effective. I recommend you use that. Okay, list 3 dietary modifications for a patient with hypertension. This would commonly come up on the NCLEX, let me tell you. Ooh, Sybil, very good. Yeah, DASH diet, DASH diet. You guys got it. Low salt, low fat. I love it. Can anyone think of anything else? So I bet most of you are going to say, okay, low fat, low salt. There's a couple other things, though, that are kind of sneaky and hidden: caffeine, alcohol, more potassium. Good job. Very clever. Fiber would be good too. I agree. Fresh foods. You guys are doing so well. Avoid smoking. Yes. Let's see. Yeah, beautiful job, guys. Exactly. The ones that are obvious, the big one is sodium. That has to be low because remember, water follows sodium. And if there's increased water in the vasculature, that's going to raise your blood pressure. So you need a low sodium diet. But some of the hidden things, caffeine, alcohol, those substances can raise your blood pressure. So really, you should cut those out of your diet. And then one I bet a lot of people didn't know is you should actually encourage a potassium rich diet because potassium actually counteracts the effect of sodium on blood pressure. So it counteracts sodium in the system. So not only should they have a low sodium diet, but when you give potassium, it counteracts sodium. So water isn't going to follow sodium as easily, and therefore the blood pressure is not as likely to go up. So that was one that was, I thought, tricky to know. So good job if you got that. Okay, this is a good one too. It says, what are the signs of dehydration in an elderly client? Mm, I like that skin turgor. Yeah. And remember, when we're checking skin turgor, the back of the hand is very effective. Back of the hand, we're looking for that tenting. If it's healthy, snaps back down. Dry mucous membranes, dry skin, skin tenting. Ooh, changes in the level of consciousness. Vital sign changes. Very good. Confusion, oliguria. Very, very good. I think you guys pretty much got all of them. Exactly. There's going to be those dry mucous membranes, decreased skin turgor. Skin's going to be tented. There's going to be very concentrated dark yellow urine, not very much either, that oliguria. But it's also going to change their mental and level of consciousness status. So look for confusion, look for dizziness. And just like you guys said, look for the vital signs. If the vital signs show low blood pressure, high heart rate, that's a sign of very advanced dehydration. Okay, this is a good one. Describe the differences between a regular diet and a clear liquid diet. And then I'm going to take it a step further and talk briefly about the full liquid diet because I think that gets confused with clear liquid. Exactly. Clear liquid is see-through when you hold it up to the light. Yes. That's how I remember it. Good. Yeah, you guys know the trick. Yeah, and exactly. Regular basically means there's no restrictions. You can pretty much have everything you want, versus clear liquid is see through. You guys got it. So, clear liquid is going to be things like water, broth, tea, juices, and a regular diet includes more of the solid foods. Now, if you're like me, what I got confused by was what's the difference between clear liquids and full liquids, or I really had trouble with those. And really, the difference is with a clear liquid, when it's in its melted form, just like you guys said, it's going to be see-through. So this is tea. It's see-through when I hold it up to the light. A popsicle is see-through when you hold it up to the light versus a full liquid. When you hold up a full liquid to the light, you cannot see through it. It is too thick. It's too viscous. So that's the big difference. All right. Next question, explain the importance of monitoring intake and output for a client with renal failure. This is good, especially if you were with me yesterday for the renal lecture. We did a live lecture yesterday on the renal system. Yep, Jello would be clear liquid because when it's melted and you hold it up to the light, it would be clear. Yeah, good question. Good. Yeah, tells us about our fluid status. Good. Yeah, it helps us to monitor the fluid and electrolyte balance. Exactly. Helps us to determine to an extent kidney function as well. So exactly, monitoring helps to assess kidney function and fluid balance, which is really crucial in managing renal failure. For any of you who were able to join me yesterday for the renal lecture, you'll remember one of the jobs of the kidneys is to decide how much water goes out of the body and how much water stays in the body. But if the kidneys are failing, they can't do that job very well. They can't move water out of the body. So you're going to end up in fluid overload, and that could sneak up on you unless you're monitoring those ins and outs. You need to maintain that normal fluid balance to maintain a healthy client. And you got to watch that really closely for renal failure clients, of course. Okay, next let's do some questions on comfort measures. So this question says, what are some comfort measures you can provide to a patient experiencing anxiety? Ooh, I like this one. Very common for clients to have anxiety in the hospital setting. I know I was when I was in the hospital. Beautiful. Box breathing, deep breathing, talk with them. Now, if we're going to talk with them, how should we talk with them? What method do we use when we're talking to them? We're validating their feelings. I love that. Therapeutic communication with active listening. That's what I'm looking for, guys. Use empathy, eye contact. Very good job in the chat there. Calm, acknowledge their feelings, don't dismiss them. Beautiful. Yeah, deep breathing. Therapeutic communication is especially important. That's going to allow your client to open up about how they're feeling. It's going to show that you're empathetic and that you care and that you're actually listening to their concern. And of course, there's a variety of relaxation techniques, music, dimming the lights, a variety of things you can do there. Now, specifically, if you have a client in pain, how do you create a soothing environment? It's probably going to be fairly similar to our last answer, but a little different. So think about someone who has the worst migraine ever. It's like, oh, my head is killing me. How do we create an environment that limits their pain, helps them deal with that? Mm-hmm. Beautiful. Dimming the lights is very important, especially with certain types of pain, like those darn migraines. Limit noise as well. Limit stimulation. Yeah, ask if they want the curtain or the door closed. Lovely. Beautiful. Yeah, dim the lights, quiet the environment, put them in a comfortable position, kind of work with them with pillows and blankets and positioning of the bed, and soothing music, a calm show, those type of things can kind of distract you from the pain as well. I agree. Okay, this one's pretty simple. I'm going to do this one really quickly. I bet you guys get this one no problem. Describe the process of administering a warm compress to a client. So think about someone, they just had, let's say we had someone who just gave birth and they're having cramping after they gave birth, and we're going to give them a warm compress. How would we do that? Ooh, make sure they don't get burned. Exactly. Good job. Yeah, we want to put not direct heat on the client's skin. We probably want to cover it a little bit. And it should only be for a certain amount of time. It shouldn't be left on for hours. I agree. Just a limited amount of time. Good. Yeah, very good. Yeah, all you do, you guys know this. You want to soak a clean cloth in warm water, wring it out so it's not dripping all over your client, and apply it to the affected area. But like you guys say, don't put something really hot directly on the client's skin. Put a cover over it. Check to make sure that they feel like the temperature is comfortable, especially for diabetic clients. Good point. Because remember, guys, diabetic clients might not be able to sense heat the same way that someone with normal sensation does. Okay, we have time for just a couple more questions here. Okay, tell me, what is the purpose of guided imagery and how can it benefit our patients? What is it and why is it beneficial? Mm-hmm. I like that. Distract them from the pain through imagination. I like that. That's a good way to put it. Distract from the pain. Yeah, that's really what it is at its core. Exactly. Yeah, guided imagery is really cool. Basically, it helps the client to visualize different scenarios. Again, they kind of use your imaginations, like you said, and it promotes relaxation, it reduces anxiety, it can help with things like pain and stress. It's very, very effective if your client is open to it, right? Some clients are going to be like, no, I'm not interested in that, and don't push it. But for clients who have an open mind, it really can be effective. Okay, we're going to wrap up with just a couple questions on positioning and then we'll call it. We're just going to have time for maybe two or three here. Okay, so this question says, and you guys talked about this already, positioning. So I'm sure you're going to do well. What is the primary goal of using the Trendelenburg position where the head of the bed is lowered and the feet are elevated? This comes up a lot on the NCLEX, let me tell you. Yes, good. That's it. Helps circulation. Also for a prolapsed umbilical cord. Good. That's kind of a sneaky one. But hypotension, hypovolemia, shock especially. Yep. Yeah. Yep. It facilitates the venous return. It helps the blood get to two of the most vital organs in the body. It's going to help the blood get back to the heart, and then the heart can oxygenate that blood and send it where it needs to go. And it also helps that blood and oxygen get to your brain, one of the most critical organs of all, of course. So we use it especially for hypotension, hypovolemia, that sort of thing. Okay, let's wrap up with one more question, guys. And that's true. I'll acknowledge that. Actually, that is very true. If you have someone in labor and delivery and they have a prolapsed umbilical cord, we're going to use Trendelenburg, and we're also going to have the client do a knee to chest hold to open up the pelvis. Very good. That's sneaky. That's a sneaky one. Okay. Finally, which position is recommended for a patient with difficulty breathing or someone experiencing respiratory distress? Tripod could work, but let's think about this. Let's say you have a client, they're having a pulmonary embolism and they are in like serious distress. They're gasping for air, their respiratory rate is high, their heart rate is high, their SpO2 is dropping. What's the best position in a real crisis? Yeah, you guys are exactly right. It's true. Tripod positioning it can help open up the lung capacity a little bit, but it's really Fowler's position that is most effectively going to help someone breathe, especially high Fowlers at that 90-degree position. If someone has a pulmonary embolism, you pull the head of the bed up, and that's usually the very first thing you do. Okay, we are going to end there. We are officially out of time, but it was really, really fun doing questions with you guys. Like I said, you came up with answers that weren't even on the answer key. So you guys did really, really well. Thank you for joining me again. We love working with you guys here at Archer. And remember, we're not just a prep course. We are a group of people who used to be in the same place you are. I remember when I was training to take my NCLEX, I was scared, and I remember that. And we care about you. We want to do what we can do to help you pass your NCLEX. So again, thanks so much for joining us. It was really, really fun. I hope you guys have a great rest of your day and take care, everyone. Thanks so much.